It's a memorial with a bat.
Did you read the last rites before you?
No.
No.
But I did do a funeral for one of our dogs. I buried our dog in the backyard, did a whole funeral for it. Yeah. I do love animals.
And you should have given it a funeral because you murdered it.
Hey, I can't remember a single serial killer that's, done last rites over their victim.
It probably is. They swarm this time of year, that's what I'm saying. Especially in my area.
Well, just call me.
Just call me? I thought it was a frog at first.
Bet me into the rest.
Alright guys, lateral sternum. So, big star here guys. We're going from that 30-inch SID now to a 72-inch SID. And I already asked y'all this last week. What's the main reason we do that?
Reduce magnification.
Reduce magnification, because naturally when we're in a lateral position, guys, where's the sternum? Anterior center point of the torso. There's going to be natural OID there, magnifying that part. Thus, we got to pull that SID back to reduce the magnification and fit it on that X-ray. What do you think would happen if you did this at a 40-inch SID? Like, this is too close to this picture, matter of fact.
Yeah, I was gonna say that is the wrong place I need to.
They're doing that to show you the tube centering, but what would happen if you actually performed your lateral like this? It'd be too big, you'd probably miss it on a 10x12. It'd be so magnified that you could cut the top or the bottom off, or both. So it's gonna be vital to get that 72-inch SID. Well, he looks really disinterested in this picture. He's like, bro, can we just stop this? Upright, I put that in bold.
His superhero pose.
Upright is in bold because, once again, optimally, guys, standing is going to be the best method for this to puff that chest out properly. Because we do have to separate that sternum from the anterior chest wall. It will become superimposed on breast tissue, lungs, ribs, everything in that chest area. So we got to puff that chest out. Make sure you do that in lab as well. And standing, of course, would be ideal because they're not going to have as easy of a time puffing that chest properly if they're lying flat on their back. Dorsal decubus, that would be a last resort if they can't stand to accommodate the patient's condition. And we can do this as a right or a left, but just like with chest x-rays, normally we'll do the left lateral as a default. So centering is going to be a big deal in this as well, because what you want to really master is grazing that anterior chest wall, trying to center on that sternum. A lot of people will center too much in the middle of the torso, and think about it, you're actually missing the sternum completely if you center right here. You want to graze that anterior chest wall. We're not doing it like a lateral chest, it's a little bit different. That's what they're doing right here.
How would you do it for a woman who has like big tissue or breast tissue?
We're going to get to that. There's a method which I would not recommend ever doing, but there is a method. It's recommended. All right, so we're going to center the sternum to the midline of the grid because the sternum is the star of our show. Once again, we're not centering the mid-torso, we're centering the sternum. So when they puff that chest out, make sure they puff that chest out before you center them, otherwise you're going to be off-center. If I center my patient with their chest relaxed, then puff the chest out, my sternum is going to move back towards the mid-torso, and I'm going to end up missing the part. So puff the chest first, then put that centering on that anterior chest wall, very thin area. Now, for the upright, we also want to rotate that shoulders posteriorly. That's part of puffing the chest out. Pull the shoulders back. That's going to move that sternum as far anterior as possible and separate it from the breast tissue, the lungs, and the ribs. If you're doing that x-ray relaxed, you're not really going to be able to see that sternum very well. It's going to be superimposed. Now, to answer your question, Melanie, now I do not recommend doing this, and I failed to see how you would ever pull this off correctly. It says large breasts for your female patients can be drawn to the sides and held in position with a wide bandage to not obscure the lower portion of the sternum. How you would ever accomplish that, I do not know. I've never done that in my entire career. I don't recommend you ever do that in your entire career. But should you choose, you can take them to the side. Yeah.
So when I was in bone putting, I told you the story.
Yeah.
They had
Yeah.
So and she just helped.
Help him to the side.
Yeah,
Right.
because they had to take the shot, and one of the techs asked the other one, "What is that?" And the other one, who shall not be mentioned, is so crass. He was like, "That's her breast. They're just hanging down there."
Oh, is that my friend? That's my friend? I figured.
Did I
I
ever
said,
tell,
I'll tell her.
did I ever tell y'all that patient that Anthony, the president of St. House had, where a woman's part of her breast fell off?
Oh, no,
Wait,
you
like
did
what?
not.
Where? Wait, what?
Hang on, I'll tell you that in a second. Let me get through the rest of this slide. So, because this, I've never heard this, this is bizarre. For recumbent,
Pop it? Like,
for recumbent, we're gonna extend the patient's arms over the head, but it's only if they're lying down, guys. Hands over the head, only if they're lying down. It's gonna help us achieve that same result, puffing the chest out. Okay, not ideal, we wanna have them stand preferably. Rest the head and arms on a pillow, and then place support under the lower thoracic region to get them in that true lateral, to avoid that natural curve of the body. So he was telling me about this patient that came in, and she had had some kind of augmentation surgery on her breasts, and she had bandages still on. So they were, I'm trying to figure out how he put this. There were like these little metal beads on the bandages, so you need to remove them to not show up on the x-ray. I don't know why those beads were there. I think it was something to do with the augmentation. Yes, that's what we're getting to. So he asked her to remove the tape, and he said she removed the tape and her entire nipple came off and just fell to the floor.
Oh my god.
So
is that about
he says he's standing there just looking like, are you okay, man? When he said his tech kind of did the, you know, that Homer Simpson thing going into the, he like hid in the corner. He ran to the back and said, "What do I do?" He's like, "I don't know. That's your patient." And the tech took off and left him there.
Oh my
Oh my
god.
god, what kind of tech is that?
That's horrible. Anyway,
what
I don't know what happened there. Or what, I don't know what was going on, but apparently she taped it back on and got the X-ray. And
But that's like
So
infection.
Yeah.
Hey,
I
that's
don't
her.
know.
That's
I've
her
never-
body.
I've never seen
That's
that happen
above
before.
her.
So.
I know. Can I suggest you go to the doctor?
She had some kind of augmentation surgery, and I guess the stitches weren't. I don't know if the tape was just holding it. Or
The
the
stitches ain't stitching.
Something wasn't right. So.
You go white.
That would have
At least do that.
I got some hot glue in the back. Let me just.
Hold on 1 minute, right?
I think I would have the same reaction. Like,
No, that gorilla glue.
What do I do?
Do I pick it up? Do I leave it?
No, give it that gorilla glue.
What do I do?
Ah, roach.
I would have been like, oh my god, Silica, you look.
No, that gorilla glue would have helped.
Was she bleeding or?
No, he said that's just it. She wasn't bleeding or nothing. It just fell off. And there was, he said there was just a hole there.
No.
Oh no.
Yeah, it was just a hole. He said.
Like, do you mind if I take a picture of this?
Not appropriate.
I'm gonna do something like that.
You're sitting there like, is this real life?
I always say, guys, you know, that's the rewarding part of this career. Every time you think you've seen it all, I swear you haven't. Something new comes in every time. So I still hear new stories every year. Okay, so big star, guys, because I said this respiration is going to change. What do we do for a lateral? Only deep inspiration. Inspiration this time. See how it can be confusing? Only inspiration for the lateral sternum. Perpendicular central ray. Breathe in and hold your breath, just like a chest x-ray. We're entering the lateral border of the mid-sternum, and on that image, we want the entire length of the sternum, once again, which is why we're going to center with them pointing to both parts, make sure we're in the middle of that sternum, because that length does vary between patients. Now, another way we can optimize and make sure we're in that true lateral, guys, is we look at the superimposed SC joints, the medial ends of the clavicles. We want them superimposed on top of each other. That tells us they're true lateral and there's no rotation going on. Yeah, Anthony tends to come in with the most interesting stories, I will say. He had another patient in surgery where like the doctor threw a big chunk of flesh at him or something. Some of our body parts falling on the floor with him. Because there was a big giant chunk of meat off the patient. The doctor threw it. It like landed right by his foot. I said, oh my God.
Oh man. And I would have threw it back.
Hey, Kobe.
Oh my
I thought you were passing.
Oh my God.
That's what I love.
Get over the fact that you said about that too, thing, that you had to clean up.
The BE?
Oh, clean the food?
Yeah, like I would hate my job after that.
That was my first day as an X-ray tech. My first day on the job. That was what the worst part was. I was like, oh my God, I made a terrible mistake. My career choice. Yes, on something. So what I do is, we usually always start with the REO, typically. That's always what we should start with. When we find the syringe with that REO, the syringe is actually not going to change. The only thing I'm going to do is pull the SID back. The syringe should still be in the exact spot. I just need to adjust my collimations and pull the SID back at that point. Because as you pull back, the black field is going to get bigger. So I wouldn't move it at all, because you're still going to be on the center of the sternum after that REO. But if you start with the lateral, you can still do the same thing. Put them in that AP first, then turn them to the side once you find your centering. That's just my personal recommendation on that. Yes?
So in that picture, you know how you can see the left side of the lateral sternum? So would the doctors order like left or right lateral sternum?
It's actually the right side. The right side is closest to the IR.
But we're seeing the left.
We're seeing the right side.
Oh,
You always
right
see the
side.
side that's touching the IR.
It's in the IR. Oh.
But to answer your question, typically no, it's just a choice. Sternum, it doesn't matter if you're left or right, you're gonna still see exactly what you can see on that X-ray. Well, we talked about some weird stuff this morning. Okay, evaluation criteria, of course, star of the show, guys, sternum in its entirety, equilibrium, free of superimposition. We get that by pulling the shoulders back. If the shoulders are not flexed posteriorly, they actually may superimpose that manubrium slightly. That's why we puff that chest down. Sternum free of superimposition by the ribs. If the chest is relaxed, it's going to be on the ribs. We're not going to see it very well. We want to push it away from the ribs. And then the lower portion unobscured by breasts of a female patient. You know, get the tape out if you're brave enough. I don't think you really have to do that. But optimizing the film, it says move the breast tissue all the way. I've never had to personally do that. I think it still looks pretty good. And then, of course, proper collimation and proper technique to see that high detail. What it's talking about with the breast tissue, it can obscure this portion right here. If the female has very thick breasts, it'll blur out that xiphoid process. But once again, me personally, I've never seen it obscure it that much that I feel the need to do what they're saying, like take them to the side. Of course, I work primarily with
Children.
pediatrics, so I don't really have the best context on that. We did a lot of sternums on kids.
Body structure, like the lung structure.
Yes, it is. It's the fine detail of the bone. Any questions on the sternum x-rays?
Are these mandatory?
No. I think everything in this chapter is elective.
The ribs are unusual. The ribs.
I think just the PA ribs would be the only mandatory. If we're talking about mandatory as far as comps though, none of these are mandatory. These would all be electives.
I've seen.
Ribs come in a lot in the clinics.
You'll see them at golf game.
I saw it up in the.
I haven't seen none of this. But she had to pull out her book.
You'll see it at golf game.
Golf game? Okay.
All right, let's move on to SC joints.
She used to do a lot of sternums.
All right, so SC joints, we're going to talk about two positions. We're going to have the PA and the PA obliques. PA and the PA obliques. Our PA is going to be our bilateral exam. The PA obliques will be our unilateral exam. PA will be a bilateral exam, ideally. There are some exceptions to that. PA oblique will be strictly a unilateral exam where we open up one SC joint. And the PA oblique can also be called the body rotation method because we slightly rotate the body. Thus the oblique. That'd be a good thing to write down, yes. Always wanted alternative names. can see maybe one name written down. All right, let's start with our PA. By the way, that should not say body rotation up there. I'm sorry. Hang on, I'm crazy. I should just say PA. PA, sternoclavicular joints. Now this can be done prone or upright, and this is the only position where I would say the ideal way to do it is laying down. Usually we always opt for standing if we can, and while this can be standing, it's better to typically do this face down on the table, prone. Now you'll notice the way this guy is laying is a little different than you saw in lab, because what did y'all do in lab? Y'all did it sitting in lab?
I did.
Okay, usually we do it laying down in my lab. So you can do it either way, but aside from that, on lab, you rest him on the chin, correct? That's what I want you to look at. Now there's a reason his head's to the side, because we do have an option of doing these unilateral. If we want to only look at one SC joint, we would turn the head towards the affected side, but ideally, we're gonna go ahead and do all our PAs bilateral. That's the optimal way to do it, because they want to do what we call comparison view of both side by side. Don't let that throw you off. That picture has his head to the side, but typically they're gonna be on the chin, because usually we'll do this bilateral. So, centering, guys. The IR will be centered at the level of the spinous process of the third thoracic vertebrae. Now, how do you find that? Because we can't really eyeball that, right? What'd y'all learn in lab? How do you find the
C7.
third T vertebrae?
You start at C7?
You find C7, also called the what? Vertebral prominence, and you go how far? Inferior. 3 inches inferior. So find your vertebral prominence, 3 fingers down, or however many fingers you need for 3 inches. 3 inches inferior to that vertebral prominence, and that's exactly where you need to be, dead on the center. Your arms will be along the sides with the palms facing upward. That's whether you're standing or laying down. Shoulders in the same transverse plane. That means just the shoulders are nice and relaxed. They're even. Now, once again, most of these will be bilateral. When we do it bilateral, it's not going to look like the picture. It'll look like lab. We're going to rest the head on the chin so that the MSP is vertical. Rest the head on the chin. If they opt for just one side, which I've never seen them do this, if it's unilateral, turn the head to face the affected side and rest the cheek on the table. So we do have 2 methods. Ideally, we'll always do this bilateral though. That's the best method. And these usually come in bone clinic, by the way. I've seen these quite a bit in Tom's bone clinic. Pretty easy comp to get, actually. Jay or Johns, do me a favor on that, because this is really bothering me. On that little box up there where it says where great features start, please fix that to where it actually looks like an E. That looks really wrong there. I'm not going to mention why, but it looks like an O.
Or grade features start.
Yeah.
Yeah, we are near Bissonnet, so.
Thank you. That was just really bothering me. I sent the wrong message.
I still remember with effective. You know what I mean? Like the difference between.
That's a very common mistake, especially, I do a lot of writing, a lot of essays, and even I mix them up still
And
sometimes.
also people mix up then and that. I don't know how.
Yes.
People who mix up their then
Then is a time.
there, there, two.
Why do they
Then-
mix them up?
then
No,
is a
I know what
time.
you mean, but I'm saying like why
Van
do
is
they?
a comparison.
Yeah.
Y'all want to write an essay next, the summer, we'll talk all about that.
I hate reading the word organ.
If you want to, it's optional. I encourage you to though.
What did you just say?
You heard me.
I would like to bring research class back, but I miss that class.
Do it next
Push on reading a lot.
with the juniors. Now we're done. We can't handle it.
Why do you want the palm and not just, why do you?
Comfort. Because if you ever try to put your palms down when you're laying like this, it's gonna be really awkward. All right, so respiration, guys, I told you how it keeps changing. Look at how it changed again. We're now suspending at the end of
Expiration.
expiration. Expiration. So it looks like they're going back and forth. CR is going to be perpendicular to IR, entering at T3. And as y'all mentioned from lab, we are going to collimate to a 6x8. That is very important because these can be difficult to see. You want that tight collimation to really accentuate and show off those SC joints. So 6x8 is what is recommended for your minimum amount of collimation. You can go even further if you want to be a super tech, but at least 6x8. Yeah, I think this guy's expressions has matched y'all this morning on this video. He's like, oh, make it end. It's the most Monday of Mondays.
This was the only one that's at 6 by 8, right?
Well, the oblique is going to be as well.
This isn't the body rotation method either, correct?
No,
Look at this
that's,
figure.
I'm sorry, yeah, don't write that down. This is just the PASC joints. The body rotation is gonna be the obliques.
Oh.
All right, so what are we looking at, guys? Of course, well, I think it's obvious who's the star of the show, our SC joints. But also, we do want to include the medial portions of the clavicles. That's to ensure that we are able to see the SC joints in their entirety because it's the sternoclavicular joints where the clavicle connects to the sternum. We also want no rotation on the bilateral examination. Slight rotation is allowable on the unilateral, even though, once again, we're ideally not going to do that method. We usually opt for the bilateral. If it's bilateral, it should be 0 rotation. Good collimation, of course, proper technique to see those trabecular details. This is what we want to see in this top picture right here. Those two comparison SC joints. It's funny that it says unilateral because we still see both.
I was about to say,
Yeah. Which is probably why we always opt just for the bilateral anyway.
Yeah, the airline is freezing in here.
They still have not turned the heat on in this building. I think because the temperature's been so wonky.
Oh my
It is a little
God.
chilly in here.
It's hard to put your marker on this one as well, huh?
Yeah, it is. It is.
So we can use digital.
No, you cannot.
I wish
So
our
what do we
markers
do?
were like a little bit smaller. 'Cause they're so big.
Y'all do have
Can
really
you
big
can you
markers.
turn them sideways? Will y'all take that?
I allow that, yes.
As long as our initials show, or as long as just.
As long as a portion of your marker shows up, because like even like if you're coming for a small finger, you can't get your whole marker on there. But as long as you can see like the R and a part of your initials, that's usually considered okay.
Well, I didn't know that, I usually leave the colors with my marker, you can see
So you
my
can,
eyes.
cause I thought y'all needed to see the whole marker. I thought so too.
Mm-hmm.
So for bilateral, no rotation, unilateral. Slightly rotation.
Correct. And that slight rotation comes from turning the head. So as you turn your head, your SC joints naturally oblique.
Mm.
Oh, so their head has E streak.
Oh, is that what you're talking about Friday? Saying if there's an easy way to cut the
Yeah, like turning the head and then like putting one arm up and one leg across the other. I'll show you on
It's the leg. Why the
I
leg?
think Mr. Fong just, he said as you put the arm up, you're already rotating.
You start rotating in. It's a very slight oblique.
You put this down, let's say you're doing the left side, right, you put this head, this side up, you're rotating,
Mm-hmm.
or this side.
Correct. Yes, Shaheen?
But they're marking one side, but they're showing both sides of the sternoclavicle joints.
Yes, because it's a bilateral study.
That's what I'm talking about. The bottom
Yes.
one it says unilateral, sir.
Yeah, but it's still technically showing both, which is why I said don't do this method. It's just another way you can do the X-ray. We typically do not do this. This is
Should
the
have
main one.
collimated, sir, right? In the unilateral, should have collimated.
I mean, you really can't because you're still sitting in the middle, and
If you comment, it's gonna be too.
just don't think too hard on this. We're not going to do this method. It's just another way of doing the same thing. I suppose the only reason you would ever do this, just based on me looking at it, is when you turn the head, you slightly open up that one side more. But this is what they're always going to order up here. They're not going to do this.
For this one, do you still need 2 markers if it's bilaterals?
No, you do not. Not for this one.
Oh.
Good question, though.
I'm gonna try.
All right, guys. So this is the body rotation method because we're obliquing the body. obvious. PO oblique, we can do REO or LEO, but we need to know what affected side you're looking for. For an REO, REO, we're gonna look at the right side. LEO, we're gonna look at the left side. We're looking at the side that is down on these SC joints. The side that is down. So the affected side is down. Very slight oblique, 15 degrees. And just like Monsi was saying, there's a little technique to get them in that natural 10 to 15 degrees. It's a very slight oblique, we don't have to turn them much. Basically, if we're looking at my right side, if I'm on the table, imagine I'm laying down, we're gonna turn my head to the right. That's gonna start obliquing me to the, lost my train of thought. That's gonna start obliquing me to the right. I'm gonna bring my unaffected arm up, and that's gonna put me in the 10 to 15 degrees oblique. Turn the head, opposite arm up. Now see how I'm laying? This is for the right side, left side. Turn the head left. So turn the head towards the affected side, bring the unaffected arm up, and you're gonna naturally oblique the patient about 10 to 15 degrees without having to actually turn their body. It's just a little easier. It's a very slight oblique. You're barely moving them.
So the affected side is the one touching the
Yes.
But the opposite.
Is away.
But the affected side.
He's not in the correct position. He's doing it, so don't, that picture's gonna throw you off there.
Cause it's supposed to be the left side, right?
Into RAO or?
So his arm is not up, it's actually down by his side as well, right here. Now what he should do ideally is bring this arm up, right here. You know what, he's actually positioned completely wrong in this picture. His head should be turned this way.
He got tired.
Because we're looking at the side down, we're looking at the sternocleidomastoid joint close to the IR. He should have his head towards us in this picture. That's what's throwing me off.
That would close off the joint space?
Yeah. This is actually counterproductive what he's doing here. That's interesting. I'll have to look that up, make sure Merrill's didn't make an adjustment to that. Because the way we used to do it, you always turn the head towards that side that is down and bring that opposite arm up. Let me double check that. I'll have the answer by next class. I'm pretty sure you turn the head towards the side down, so we're always looking at the side down, which it says right here, SC joint closest to the IR. Suspended into expiration. We're still airing the same spot, by the way, about T3, which is about 3 inches below the vertebral prominence, and slightly towards the arm side. And we're still gonna use that 6x8 type combination field. Yeah, I'll double check, guys, and make sure on that. We'll review that on Wednesday. Make sure you have the right info. Meryl's just made so many changes in this newest edition. I want to make sure that we're accurate.
I'm not gonna write anything, because then I'll be.
You can still write this in though. This is they're still accurate. I just want to make sure the positioning hasn't changed. Because we're still doing this SC joint closest to the IR. We're still obliquing the same amounts. We're still centering the same amounts. Just want to check the arm positions and all that. That's the one bad thing about switching to new editions. Those little variances in the positions that they add or take away. So you get stuck teaching it one way and then switch it up on you, like that 30-inch SID.
Wouldn't that be uncomfortable if you're looking at the left and
It's very uncomfortable.
Yeah, so why wouldn't you look to the right then?
That's why I don't know if it's I don't know if it's a bad picture or if they changed something. That's why I want to make sure.
Cause I'm trying to get.
Yeah. It's from the book.
How do you get the toothpaste off?
I like it. So I have
These shoulders
I
are
have like
stiff. I
the
can't
teacher's version of
Oh,
the book. It has all the images and everything. Just transfer them over.
So if we're doing LEO, the light will go straight to the
To the elevated side, yes.
right.
That's right. Yeah, so still that same concept applies when you're doing oblique, guys. You still always steer slightly towards the elevated side. If you don't, you end up cutting off the anatomy you want to see. Doing the oblique throws the anatomy off. Alright, what do we want to see, guys? Of course, a slightly oblique open, I might add open sternoclavicular joints. We want that SC joint of interest to be centered, because that's the star of our show, which is what we see right there. Open SC joints. We also want the manubrium and the medial end of that clavicle included, to make sure we can see the actual open space. Open SC joint space, and the joint of interest next to the vertebral column with minimal obliquity. Side down is what we're looking at. Once again, side down. Once more, I will double check that before next class. All that positioning.
So since this one, it could be done, this one that was done prone or upright?
Preferably prone, but you can do it standing as well.
Okay. Yeah, so we look at upright.
I mean, it's the same,
For
it's still
test
the,
purposes, we're gonna do it.
just, for test purposes, it doesn't really tell you on this one, one's better than the other. I just, for me personally, from a comfort standpoint, I'm probably gonna be a little more comfortable laying down for it than standing. For this one, staying upright or laying down is fine. Unlike sternum, where they need to be standing preferably. We okay out there? Coffee didn't help very much?
Helped the first
Still right, we're gonna move on.
Move on.
All right, let's get to the ribs now. Everyone's favorite. This is the Hobbit. On the ribs.
Oh, no, I don't
Well, you should. You really should. Do yourself a favor.
I don't watch it either.
Cool.
Isn't there like 7 or 8 movies of those?
There is a lot of movies. They're very long too, but they're really good. Really good. It's a great story. All right, so our essential projections we're going to talk about, guys. We have the PA, upper anterior ribs. You do need to know it as such. Why? Put the chest up against the IR. The star of our show on PAs is the anterior ribs. Always remember, we're looking at the part of the body that's touching the IR. It's going to be very important because you can get a lot of questions based upon what position will show what part of the ribs. Posterior versus anterior, obliquity, we're going to spell all that out as we move forward. Our APs are going to show our posterior ribs. Now before I move on, we also do an AP lower ribs. But we don't do a PA lower ribs. Why is that?
We don't do what? I'm sorry, what's the
Let me say it again. Shaheen's got the right idea, but let me say it again. We always, well, not always, depending on the patient, we will do an AP lower ribs, but we do not do a PA lower ribs. Why is that?
Soft tissue.
Think about your ribs.
We got floating ribs.
Floating ribs. Do the floating ribs attach anteriorly? They do not. Thus, would it be any benefit to do a PA lower ribs? It would not. But if we put our back against the IR, we can see the back side of that 11 and 12. So we will do an AP lower. We will not do a PA lower. That's a test question. People always miss every year. In our obliques, whether we're doing the AP obliques or PA obliques, we're looking at the axillary portion of the ribs. Axillary portion of the ribs. Our AP obliques would be our LPO and RPO. Our PA obliques would be our REO and LAO. Say it again, our AP obliques are the LPO and the RPO. PA obliques are the REO and the LAO. The AP obliques are LPO and RPO. PA obliques are the REO and the LAO. And once more, true or false, we are allowed to do PA lower ribs.
False.
Not your question, it's false. Why is it false?
Because they don't connect to the.
Because 11 and 12 do not connect anteriorly. They're floating ribs. Thus, we're always going to do an AP lower. PA lower does not exist.
So, here.
We just do PA upper, but we never do PA lower. AP, we can do upper and lower. So, in other words, if I do a PA upper ribs and I still need to see the lower ribs, what am I gonna do? AP lower, we'll turn them around, do AP lower. Boy, I could get like 7 test questions out of that.
We don't do PA lower
Because the floating ribs do not connect anteriorly to the sternum. You only see the posterior portions.
Oh,
Did you do it Saturday and Sunday?
REO and LEO fits under PA oblique.
I mean, no,
RPO and LPO fits under APO oblique. We're gonna spell each of those out individually, and I'll show you what ribs, what portion we're looking at specifically, because it's very important to master that concept on those obliques.
but you just went through all last week.
And because of that, we're gonna stop here today, guys, because I don't wanna get too far into ribs, because ribs can get very complicated. We'll spend the entirety of the next lecture talking about ribs, make sure you master that, because you will